Well, good evening, everyone. On behalf of Walter Kluwer, a warm welcome to all our speakers and attendees of this oncology webinar under our MedicalEdge series. Our topic today is clinical oncology review, and we have with us our program director, Dr. Soyan Paul, who is a senior consultant radiologist oncologist at Apollo Hospitals. Today, we also have the speakers, Dr. Cecil Canickel, who is an additional professor of RCC Trivandrum. We have with us Dr. Sayan Das, who is consultant radiologist oncologist from Rana Super Specialty Hospital, Howrah. And we have Dr. Moses Singh, who is clinical oncologist from Tata Medical Center. So we have three speakers, and we have our program director, Dr. Sayan Paul, with us today. Also, we will be taking all questions at the end of the webinar, and I request you to please post all your questions in the Q&A panel of this event. We'll try to address the maximum questions at the end of the session. We also provide you the feedback link, which we'll post in the chat section of the webinar. And I request you to please provide your feedback on the session today. Now we begin our session, and I hand over the dais to Dr. Sayan Das, who can start presenting his screen now.
Thanks a lot, Shanda, for your kind introduction. A very warm welcome to you all. A very good evening. Okay, fine. So I'll share my screen now. So I hope my slides are visible.
Sir, not as of now. I can see the screen, but not the slides. Yeah, they start coming in. Yes, sure, sir. So you can maximize them, sir. Yes.
So is it okay now?
Perfectly fine, sir.
Okay, great. Fine. So thanks once again to both Walter Kluwer as well as Sanda for arranging this academic discussion. Yes, all three topics are quite interesting that we're going to discuss today. The first one, which I'm going to speak on, is the role of stereotactic body radiation therapy in hepatocellular carcinomas. Now, before I begin, there's a small disclaimer that it is mostly for the purists, that there is no level 1 evidence to support the use of SBRT in HCCs. And as such, most of the current management guidelines do not include SBRT, but I'll allude to some of them in the later half of my talk. So let's begin. Well, HCC is not the most common cancers around. In India, it's around the 12th most common in incidence and around 8th in terms of mortality. But as we all know, the survival outcomes are quite abysmal. So if you look at the data, it's around the 5-year OS is around 10%. So there's a lot of scope to improve the outcomes in this group of cancers. Now, what I believe is if you're going to study any disease, the most important aspect is study its natural history. That kind of dictates what is going to be the management. HCC typically develops in the background of a cirrhotic liver, and the disease remains confined to the liver till it is quite advanced, which means there's a role of adding some form of local treatment which can lead to improved outcomes. Majority of the patients that we see in our clinic on a daily basis, they present at an advanced stage, which kind of coincides with the state of liver function or liver decompensation, and the patients mostly die of disease progression causing hepatic failure. One very important factor that one must keep in mind is the presence or absence of vascular invasion. Vascular invasion has been shown to be a very strong negative prognostic factor. So most commonly it involves the portal venous system and rarely to the hepatic venous system. How has radiotherapy evolved in liver malignancies is something that one must have a look. So even in the pretty earlier days in the 1920s, liver was a target for radiation therapy, but it was found that use of conventional radiotherapy was causing too much of toxicity, what was known as the radiation-induced liver injury or liver dysfunction. In 1965, there was the first published report that said that the dose limiting toxicity after a whole liver radiotherapy was around 35 gray. Later reports suggest this doses should not be more than 30 grays if you're going to avoid a high risk of RILD. Now, what is this RILD? Now, what classic RILD? The pathophysiology behind that is the veno-occlusive effect of radiotherapy. It's composed of fatigue, weight gain, increased abdominal girth, hepatomegaly, and icteric ascites, and transient elevation of the liver enzymes. It typically occurs between 2 weeks and 4 months following radiotherapy to liver. However, this is very rarely seen nowadays. What is more common is the non-classic RILD, which is seen in the setting of cirrhosis or viral hepatitis, which is characterized by jaundice or markedly elevated serum transaminases within 3 months of completion of radiotherapy to the liver. Some even may have reactivation of hepatitis B virus. Radiating the liver is a challenging task. And why is that so? It's because HCC is a very complex disease. So the patients most often will have an underlying cirrhosis, which means the liver is already having a deranged function. The disease is a heterogeneous, which reflects there's different underlying epidemiological background and risk factors. So in the Western countries, it is more often seen with hepatitis C, whereas in the Asian countries or in the Southeast Asia, there's a role of HBV seems to be more important. We need to keep in mind the tolerance doses for individualized cases. Unlike SBRT for lung tumors, which will be discussed later on, where visualizing the target is much easier, is not the case for liver tumors for HCC. Along with the diaphragm, the liver keeps on moving and the shape of liver changes. That one needs to be sure about all those things. And for tumors which are close to the GI luminal structures, any change in the GI luminal filling can lead to change in your delivered doses. Just a few words about what SBRT actually is. I think most of the participants are well aware, where we deliver very high doses of radiotherapy with an ablative intent. As because we're delivering high doses, it has to be highly conformal. We need to tackle the motion. We need to take care of motions. We need to image guidance is a must, and it is usually not more than 5 to 6 fractions, which means it's high dose per fraction radiotherapy. This has become possible only because of the technological advancements. So olden days, conventional radiotherapy does not work. Today, with newer techniques, you can deliver very high doses to small volumes so as to avoid significant liver toxicity. So how SBRT came into the picture was with this idea that liver is a parallel organ, so it can tolerate much larger doses if we treat only a relatively small volume. So we need to spare an adequate amount of liver so that we avoid significant liver toxicity as well as have or achieve a significant local control. Now, as I said, the recent advances, which accounts for tumor motion, your target localization, your treatment delivery systems, all this have allowed giving highly precise high dose per fraction radiotherapy with an ablative intent for hepatic malignancies. Now, these things originated around the mid-90s and 1990s. One of the pioneering institutes was the Karolinska Institute. In the same time, similar reports were coming from the University of Michigan as well as from Japan. This is something different which one must get a grip of to understand how to deliver radiotherapy for liver tumors. Now, what standard dose prescription that we often use is based on the size. For other sites, so in brain tumors, depending on the size, we decide what's the dose that is to be delivered. For liver tumors, there is something different concept, which is called the isotoxic dose prescription. And all this that I'm showing, this concept was based on the seminal work by Professor Laura Dawson. So what she suggested is, what is effective volume of liver? It is the liver volume or the normal liver volume, which excludes all the gross tumor volume, which, if irradiated uniformly to the prescribed dose, will lead to the same risk of toxicity as the non-uniform dose distribution that we are delivering while delivering SBRT. If I give an example, it will be easier to understand. So suppose we are delivering 60 gray to the liver tumor, and around 2/5 of the liver is getting 60 gray, 1/5 is getting around 50% of the prescribed dose, around 30 gray, another 1/5 is getting around 20 gray, and I'm sparing completely the remaining 1/5. So the effective volume at the reference prescribed dose is, using this calculation, comes around 0.56, which means around 56 or 57% of the liver, if radiated to this prescribed dose, would lead to a similar toxicity. This kind of suggests that the lower my effective volume is, the larger doses I can deliver to our target. This again from that very same paper, which showed that with lower effective volume, you can offer doses like 54 gray in 6 fractions, which means a higher BED, whereas with higher effective volumes, you have to gradually reduce your doses so as to avoid significant liver toxicity. Now, is there a dose-response relationship while treating hepatocellular carcinomas? Well, yes, there is. There are several papers on this. I've just quoted 2. So if you look at the left-sided graph, what it shows is that if your doses is less than 40 gray, your response rates are in the range of 30%, which increases to more than 75% if your dose is more than 50 gray. The other paper kind of shows that the local control rates increases from 50% to 90% if you increase your dose from, say, 53 gray EQT2 to around 84 gray EQT2. So what is usually standard is you have to keep your doses around 70 to 80 gray EQT2 to have or to achieve an optimal local control. Now, what sort of a local control do we achieve with SBRT in hepatocellular carcinomas? I think I don't know whether you're able to see the table clearly, but just focus on the last column. So it looks at 2-year local control. If you see, the values range from, say, around 65 to up to 100%, even at the end of 2 years, which is amazing. This kind of tells us that yes, SBRT is effective, giving you excellent local control rates, and some papers have even achieved reported long-term survival rates. However, one needs to be cautious because most of the patients were child PU A category, and mostly 1 to 3 lesions are treated, and there's limited experience in child PU B disease. However, the other point that I must impress upon is that SBRT is frequently used in those patients who have failed or are unsuitable for the more established therapies, which I'll come to later on. Let's focus on this side. I think this is a very common, everyone who reads HCC comes across this diagram, which is the Barcelona Clinic liver cancer classification. This is one of the most commonly used working classification while managing HCC. So we have a very early stage, then you have stage A to C, and which are the early, intermediate, and advanced. and then we have end stage or the stage D. Now, if you look at this diagram, there is no mention of SBRT anywhere. I'll again come to this picture at the end of my talk, while I try to convince you about the potential role of SBRT. So what I can show from this diagram is that for early stage tumors, resection or a liver transplant, they are curative treatments with 5-year survival of around 40 to 70%. In intermediate stages or TACE is the standard of care. However, one must remember these are non-curative therapies. And in advanced stage, it is usually systemic therapy. Sorafenib, or the newer results are showing the role of immunotherapy and VEGF inhibitors. In the end stage disease is mostly based supportive care. So where does SBRT fit in this treatment algorithm? At this point in time, or today, the common indications of SBRT are mostly can be categorized into 3 groups. The first group is in early stage hepatocellular carcinomas. If the patient is ineligible for transplant or is refusing a surgery, is ineligible for the more conventional treatments like RFA, microwave, or a TACE, or even if after undergoing these procedures, there is a residual disease or there is a recurrent lesion. The second group is if you are planning to bridge or downstage for transplant. I'll talk about it in details in the next slide, I believe. The third category is, which is the most common scenario that we face, is in intermediate or in advanced HCC, especially or usually with portal vein thrombosis. Now, the common selection criteria for SBRT is usually we consider child A patients and some selected B7 patients. We must remember that around 700 cc of normal liver should receive less than 15 gray. Up to 5 lesions, but again it depends on what's the size of the lesions, is usually fit for SBRT. Commonly, no extrahepatic disease should be there. However, some people consider that minimal extrahepatic disease in the form of, say, periportal nodes which are close to the target can still be included in our SBRT portals. So, as SBRT is still evolving and it still has to fight for its place in the management algorithm, let's look at how it fares against the conventional radical local treatments. Again, pretty complicated tables, and I'm not sure how many of you can actually see the tables, but what I'll try to highlight is, again, look at the last column. First and foremost, all these trials that I'm showing here, they're all, as you can see, are retrospective series comparisons, because there are no prospective randomized data as of now with a head-to-head comparison. Trials are going on. However, what can be seen from these retrospective data is that SBRT is at least competitive with the more established treatment regimens. With compared to RFA, SBRT shows better local control for tumors more than 2 centimeters in size based on retrospective data. As I said, you need to deliver at least more than 70 to 80 gray to have optimal local control. Now the data is more robust with TACE, and I think TACE is the only radical local treatment modality that has shown improvement in overall survival compared with best supportive care alone. However, as I said, TACE is a non-curative therapy with a very high local recurrence rates, which can be as high as 60 to 70% at the end of 2 years. And TACE cannot be used in presence of portal venous thrombosis, where SBRT is feasible. What about RFA and microwave? Is that RFAs have this issue of it should be accessible, which means that subdiaphragmatic lesions are at times difficult to approach. subcapsular locations, there's a high risk of rupture while doing RFA. When the target is close to your biliary structures or your large vessels, because of the heat sink effect, RFA is not very useful. For larger tumors, that is more than 3 centimeters, the periphery gets underdosed and not, so RFA is not usually suitable for these cases. The other local treatment that is there is called the TARE, transarterial radioembolization, which can be used even in portal venous thrombosis. However, the response is low because of the lack of small vessels in the thrombus to localize the microspheres. However, TARE is pretty expensive and there is very limited availability. So other than these early stages where your conventional therapies are not available or not eligible, or they have not responded well, the other category where SBRT does have a role is for patients who are due for liver transplant but are on the waiting list. So there you offer SBRT so that they don't progress and go beyond your the Milan criteria for liver transplant. So this is known as the bridging treatment prior to liver transplant, which is more relevant for cadaveric liver transplants because there are at times pretty long waiting list. What is downstaging is if the tumor is a borderline transplantable, so it is just beyond the Milan criteria. So there you have a role of SBRT to downsize the tumors and bring them or to make it acceptable as per the Milan criteria for liver transplants. This is, however, more relevant for living donor transplants. Just to quote some data, so almost close to half of the patients drop off the waiting list if they are waiting for transplant at the end of even 2 years because of disease progression. And in this role as a bridging therapy, SBRT patients, 63 to 100% of the patients proceed to transplant with very low rates of toxicity and with CR rates close to 14 to 27% and PR rates of 23 to 64%. Just one point is that I think I'll come to it later on. Okay. So the other point that is there is that the prior treatment to transplant, the response to that is a good biological response, gives us a good information about how the tumor is going to behave. So those who achieve a CR with this prior treatment with SBRT tend to have much better outcomes after they undergo transplant. Can we combine these various modalities? Well, theoretically, it looks very promising if we add SBRT to TACE, because by using TACE, you can shrink the tumors, so your target volume for SBRT becomes smaller. Also, the chemotherapy may provide some sort of a radiosensitization, and for us radiation oncologists, the use of lipiodol is very useful for image guidance. Studies have shown that if you add SBRT, it leads to better local control, but no increase in high-grade toxicities. For larger tumors, OS was significantly better in one of the reports. However, for smaller tumors, probably there's no additional benefit if you add SBRT. There's an ongoing trial going on at Tata Memorial Hospital, which is looking at TACE versus TACE plus SBRT. What for patients with portal venous thrombosis? Well, recanalization following SBRT potentially facilitates TACE. So here you give SBRT first, and once there is recanalization, then the patient can be taken up for TACE. So again, the rates of CR is around 37% and PR is around 75% if you use SBRT with portal venous thrombosis. However, it can take few months to have or to achieve a maximal response. What about adding systemic therapy? Preclinical data showed that if you add sorafenib, it can enhance the tumor response, but it's pretty toxic and not routinely recommended. The RTOG study is trying to find out or answer this question. There are again no robust evidence of adding SBRT along with immunotherapy or these VEGF inhibitors. However, trials are ongoing. As I said, it's mostly used for Child-Pugh A category patients. What about B or C? Well, there are several studies. I just showing you only one prospective study on CPB and C group of patients. Again, if you see median OS of around 8 months only. But what I want to point out is that the CPB7 had a significantly better overall survival. So this group of patients may be suitable or may be feasible for SBRT. But again, Child-Pugh B8 or anything higher is probably a no-no for SBRT because you tend to have more liver toxicities. Well, let's have a look at the toxicities. So again, look at the last column, which shows that, as I said, with the newer techniques, classic RIL is very rarely seen. The non-classic in CPA or B7 is around 10 to 12%, while it can be as high as 30 to 35% in CPB8 or higher. Again, toxicity depends mostly on proximity to the luminal GI structures, which can often be dose limiting if your PTV is very close to these structures like the duodenum. Now let's look at the guidelines. What do the guidelines say? The European Association for the Study of the Liver recommends that, as you can see for this column, external beam radiation is not really recommended because there is a low quality evidence. So they're saying it is neither negative nor positive. The evidence is pretty low, which kind of I would push the enthusiastic researchers among the participants that this is one area where there is a scope to generate more robust evidence in favor of SBRT. What does NCCN say? Fortunately, it's one of the guidelines that does have added EBRT since 2019, I believe, as part of one of the local regional treatments if it is not feasible for surgery. In non-resectable cases also, along with ablation and your transarterial therapies, there is mention of EBRT, and even for inoperable disease or with comorbidities, as long as it's liver confined, there's some role of EBRT. However, it's category 2B. So again, let's come back to the very diagram that I showed previously. So what are the potential roles? So in early stages, if it is unsuitable for surgery or transplant, there's a role of definitive radiotherapy, or there's a role of bridge or downstaging prior to transplant. In the intermediate or advanced stages, if it's unsuitable or refractory to TACE, there's a role of radiotherapy, especially if there's portal vein thrombosis. And in symptomatic cases, there is a role of palliative radiotherapy. So to conclude, it's a promising non-invasive ablative modality which has a potential role in almost all stages of hepatocellular carcinoma. It can, multiple reports have shown that we can achieve high local control rates. However, optimal patient selection is vital. Here comes the role of a multidisciplinary clinic. You have to have good hepatologists in your team, a good IR team, a good GI surgeon, and your radiation oncologist and a good radiologist. And we need to generate more and more robust evidence so that all guidelines do agree that yes, there is a role of SBRT in hepatocellular cancer. Just before I finish, again, a word of thanks to Walter Skruer for giving me this opportunity. Shailendra led us this as a brilliant leader, collected, I mean, we all participated and kind of gave some effort to write this book. I would request all the residents and the junior consultants, it's a pretty useful handbook, up to date, and what is important is what you find is at the end of each chapter, you'll find a treatment algorithm to help you in your day-to-day clinical practice. Thanks a lot.
Thank you, Dr. Sayan. It was very, very informative and excellent talk. So we'll take the questions at the end of the webinar. Let us move on to the next talk now. The next talk is by Professor Cecil Keinickel. Professor Cecil Keinickel is additional professor of radiation oncology at Regional Cancer Center, Trivandrum. And most of us who are in for oncology, most of us know him. So he needs no introduction. He will be talking on targeted therapy in head and neck cancer. And Dr. Cecil Keinickel, please.
Can you hear me?
Yes, sir, you audible, sir. Sir, you can just make it in the slideshow, sir.
Yeah.
You
Okay,
can see
thank
the
you.
slides.
Okay. Thank you. Okay. Can you see my slides?
Perfectly fine, sir. Please go ahead, sir.
Thank you. Thank you. I sincerely thank Dr. Sayan Paul for the invitation and also be the part of the textbook. And I have contributed the head and neck part of the textbook. Thank you very much for again the invitation. So today I will be discussing about the role of targeted therapy in locally advanced head and neck squamous cell carcinoma. I will not be discussing about the recurrent and metastatic, and that too I will discuss along with definitive radiotherapy. I will not be discussing about the role of targeted therapy in the adjuvant setting because we will not be able to cover that in 15 minutes time. So coming to the locally advanced squamous cell carcinoma, we have the stage 3, that is T3 or N1 disease. Stage 4A is either T4A or N2. Then that becomes stage 3 and stage 4 disease. And this group of patients are amenable for radical treatment up to stage 4A, up to 70 years, and patients who have good performance status. The standard treatment is either to consider concurrent chemoradiation or you consider surgery followed by postoperative radiotherapy. In patients who have advanced oropharyngeal carcinoma, either P16 positive or negative, advanced laryngeal carcinoma, and hypopharynx without cartilage destruction and a functional larynx, the standard treatment is to consider a radical chemoradiation. In selected gingivobuccal complex tumors, also we are considering for radical chemoradiation. In patients who have tongue tumors, patients with the gingivobuccal complex tumors, bone involvement, or larynx or hypopharynx with a cartilage destruction, or advanced disease with a non-functional larynx, the standard treatment is to consider surgery followed by postoperative radiotherapy. In patients who have T4B disease, due to the primary disease, or N3 disease, that's a large N3 disease, generally they are considered for palliative treatment, that is stage 4B disease. But in patients who have small primary, good performance status, young patient, generally they are also considered for radical approach. In stage 4B, we have to individualize the patient. So young patient with good performance status, low volume disease, they are considered for radical approach. Otherwise, patients with elderly patient, poor performance status, or with a large primary with an N3 disease, N3B node, generally they are considered for palliation. In patients who have, so I'll be discussing only the phase 3 trials in the definitive setting. So coming to the targeted treatment, based on the McKenzie meta-analysis, the standard treatment to consider if your patient is considered for radical radiotherapy is to consider concurrent chemoradiation. So if you look into the role of target agents, it comes in two forms. One in anti-EGFR agents, and it is the immunotherapy. So coming to the anti-EGFR therapy, first coming to the EGFR, that is the epidermal growth factor receptor, it is expressed in 80 to 90% of the head and neck squamous cell carcinoma. And if you look into the epidermal growth factor, it have an extracellular domain and an intracellular domain. The extracellular domain is this one, and the intracellular domain. So what happens? So how the anti-EGFR agents, how the EGFR pathway activated. So that first I will discuss that. Then I will discuss the mechanism of action of anti-EGFR agents. So when a ligand binds to the EGFR, the extracellular domain of the epidermal growth factor receptor, the second step it is to go for a dimerization. So it can be EGFR or EGFR-like ligands. EGFR-like ligands are HER2, HER3. These are the or HER3 or HER4. That are the EGFR-like ligands. So when the EGFR in EGFR dimerizes, that is called homodimerization. When an EGFR dimerizes with a HER2, EGFR-like ligand, then it is called heterodimerization. That's the second. Once the heterodimerization or homodimerization occurs, then the second pathway is called, this is activation, the phosphorylation, the autophosphorylation of the tyrosine residues. This is the tyrosine, that is the tyrosine residues. Once this pathway, the phosphorylation occurs, two pathways get activated. This is a RAS, RAF, MEK, and the MAP kinase pathway. And this pathway is lead on to the progression of the cell cycle and gene transcription, the cell cycle progression from the S1 to G1 to S phase. This occurs. And what happens? It leads to cell proliferation. And this is the first pathway. The second pathway is the PI3K pathway, AKT pathway, and this lead on to the anti-apoptotic and the pro-survival and leads to cell survival. These are the two pathways And once these two pathways are activated, it leads to cell proliferation, cell survival, invasion, metastasis, and the tumor-induced angiogenesis. So how the anti-EGFR agents act? By two ways. One, it acts at the extracellular domains. All the monoclonal antibodies acts at the extracellular domain of the, and it prevents the dimerization of the either a homodimerization or a heterodimerization. And the subsequent cell transduction pathway is blocked. That is the mechanism of action of the anti-EGFR monoclonal antibodies. That includes the cetuximab, the panitumab, the salitumab, and the nimocimab. These are the agents. And the intracellular tyrosine pathway. This is the EGFR TKS, that is geftinib, erlotinib, osimertinib. This acts in this at this site. So the phosphorylation is prevented, and the subsequent pathway is prevented. The other action is the activation of the antibody-dependent cell-mediated cytotoxicity. That is another mechanism of action of the anti-EGFR. And the third mechanism is a downregulation of the receptor. So it leads to the receptor downregulation and receptor degradation occurs. So these are the mechanism of action of the anti-EGFR drugs. And this is a very beautiful article which was published in New England Journal of Medicine in 2008, describing about the mechanism of action of anti-EGFR drugs. Now coming to the phase 3 data of using an anti-EGFR therapy in the locally advanced squamous cell carcinoma, where you consider radical radiotherapy as the definitive treatment, not in the adjuvant setting. So these are the phase 3 data. Okay, I'll be discussing only the phase 3 data. So if you look into is there any role comparing an anti-EGFR monoclonal antibody in addition to radical radiotherapy? This question was addressed in the Bonnet trial. The Bonnet trial was initially presented in ASCO annual meeting in 2004, published in New England Journal of Medicine 2006, and with initially the results were, and later there was an update with 5-year result data was published in Lancet Oncology in April edition in 2010. And this is the two publications of the Bonnet trial. So how the randomization? It was randomized to arm 1 was radical radiotherapy. The radiotherapy was either a conventional radiotherapy or alternate fractionation were permitted, or you consider same radiotherapy plus weekly cetuximab. The patient were offered cetuximab 400 milligram per meter square 1 week prior to start of radiotherapy, then 250 milligram per meter square given weekly till the end of radiotherapy. So that was the prime. Then this is patients where all the locally advanced squamous cell carcinoma. Then if you look into the results, the locoregional control and the overall survival at a median follow-up of 54 months, when the initial data was published in 2006, showed there is a statistically significant improvement in locoregional control as well as overall survival. And the 5-year update showed two things. One, the overall survival was better in patients who received cetuximab compared to radiotherapy. And the patients who compared the rashes, if the patients who had no rash or the grade 1 rash or comparing other grade, that is comparing grade 1 and grade 2 to 4, there is a statistically significant difference between patients who developed rash. So this was the two conclusions from the update. And if you look into the toxicity part, if you look the toxicity, if you look into the grade 3 and grade 4 toxicity, the skin reaction, it was statistically significant, and also the infusion-related reactions were more in patients who received cetuximab compared to radical radiotherapy. The pitfall of the Bonnet trial was that the patient was not used the concurrent chemoradiation as the control arm. Because this study was started in 1996, the McKenzie meta-analysis was initially published in 2000 in Lancet. So this was before the publication of the McKenzie meta-analysis. So this was randomized between radiotherapy basis radiotherapy plus a monoclonal antibody. The editorial in the New England Journal of Medicine publication in 2006 by Marshall Sposner, which was the PA of the TAX 3 to 4 trial, and they concluded that at present for patients who can tolerate it, chemoradiotherapy with cisplatin remains the standard of care. Patients who cannot tolerate platinum-based chemotherapy for a variety of reasons should be expected to benefit from addition of cetuximab to radiotherapy. Now the second part is the concurrent chemoradiation became the standard. Then is there any benefit by adding a monoclonal antibody in addition to concurrent chemoradiation? That was the question. And 3 phase 3 trials were evaluating this problem. One was the RTOG 0522 clinical trial. This is the largest among the 3 trials because these included more than 900 patients. The second study was the nimocimab trial by Kumar Prakash from Tata Memorial Hospital. Third is the Dehenga study, 19 study using salitumab. The RTOG used the 0522 clinical trial compared concurrent chemoradiation versus concurrent chemoradiation plus cetuximab. The same design of the concurrent chemoradiation was concurrent chemoradiation plus cetuximab, advanced head and neck squamous cell carcinoma patients. This data was presented in ASCO annual meeting in 2011, published in JCO in 2014, with the 2-year results were published. And if you look, the primary endpoint was progression-free survival. If you look into the progression-free survival, 3-year results, at a median follow-up of 3.8 years, in a 3-year progression-free survival and 3-year overall survival, there was no difference between the arms. And there was a 10% increase in grade 3 and grade 4 toxicity. The conclusion is that the cetuximab, in addition to the concurrent chemoradiation, is not of any benefit in locally advanced head and neck squamous cell carcinoma. The second study is from the Tata Memorial Hospital by Kumar Prakash. This was 536 patients were randomized either to give concurrent chemoradiation. The concurrent chemoradiation was 66 to 70 gray plus weekly cisplatin, that was 30 milligram per meter square weekly, versus the same chemoradiation plus nimicitumab 200 milligram flat dose given weekly till the end of radiotherapy. So this was the primary endpoint of this study was the progression-free survival, and there is secondary endpoints were local control and overall survival. At a median follow-up of 39 months, the data was initially presented in ASCO annual meeting in 2018 by Dr. Vijay Patil and published in Cancer in 2019, showed that there is a benefit in terms of progression-free survival and local control. And this is the only trial which have shown there is a benefit in terms of progression-free survival and local control for a monoclonal antibody in addition to chemoradiation. If you look into the overall survival, there was no benefit. The p-value was not significant in terms of overall survival. If you look into the toxicity, there was an 11% increase in grade 3 mucositis in patients who received nimicitumab compared to concurrent chemoradiation. So that then they have done a subset analysis. Always we should interpret the data with caution for a subset analysis. The data was published in Onco-Target in 2020 in January issue for a 187 patients. If you look into the subset analysis in patients who have HPV negative carcinoma oropharynx, there is an improvement in progression-free survival and overall survival. Both were statistically significant, but this was a subset analysis. The third trial is the salitumab trial by the Dahanka group. And to best of my knowledge, this paper has not been published so far. This was presented in the Astro Head and Neck Symposium that was held in February 2014. And this was this accelerated radiotherapy. You know that Dahanka follow an accelerated radiotherapy that's 6 weeks per week, plus a nimorozole, plus a weekly cisplatin, basis the same chemoradiation plus salitumab that is given 8 milligram per kg. So this was the design. The primary endpoint was the locoregional control. So all the trials differed in their primary endpoints. The RTOG trial, the primary endpoint was OS. The TMH trial, it was progression-free survival. Here it is the locoregional control. At a median follow-up of 36 months, there is no difference between the 3-year locoregional control, which was the primary endpoint. But there was a 29% increase in grade 3 and grade 4 toxic rashes in patients who received an EGFR, anti-EGFR agent compared to patients who received chemoradiation. So if you look all the 3 trials, none of the trials show any survival benefit. And there is an increase in toxicity across the board. And the TMH trial showed an improvement in progression-free survival and disease-free survival. So the conclusion is that we need more robust data to accept this as a standard or to incorporate anti-EGFR therapy in addition to the concurrent chemoradiation. The third approach is after the publication of the Bonner trial, especially in patients who have a low nodal disease, there was a trend to use a radiation plus cetuximab as a standard treatment. Then the question was asked by the French group: is there any benefit by adding chemotherapy in addition to radiation plus cetuximab? This was mainly in low nodal disease. And this was addressed in the GOTEC 2007-01 clinical trial, which was published in JCO in 2018. The primary endpoint of this trial was the progression-free survival. The patients were randomized to either you give cetuximab plus radiation or cetuximab plus radiation plus chemotherapy. And 3-year progression-free survival was better in patients who received chemotherapy in addition to a monoclonal antibody plus radiotherapy. So that is the conclusion, although there was no difference in survival between the 2 arms. And if you look into the locoregional progression, it was less in patients who received chemo. That is, the locoregional progression was less in patients who received chemotherapy and no difference in distal metastasis. That is the conclusion of the GOTEC 2007-01 clinical trial. Now, the fourth attempt was, can we replace a chemotherapy with a monoclonal antibody? And this was the question asked. So for cisplatin plus radiotherapy basis a monoclonal antibody plus radiotherapy, because we know that the radiotherapy is the pillar of the treatment. Then there are two studies. There's the ArtScan trial, the 3 trial that was done in Sweden, Scandinavian countries, and second is the HN6 trial. This was done in Canada. And the agent was used in the ArtScan phase 3 trial was the cetuximab, the concurrent chemoradiation standard arm basis radiotherapy plus cetuximab, say in the bone of it. And this was the primary endpoint of the trial was to overall survival. The study was study was prematurely closed because the patients who received the chemoradiation had a better survival, and the study was the data independent monitoring committee advised to stop the trial prematurely. And 3-year overall survival was 88% basis 78% in patients this study was prematurely closed. And the local control were also better in patients who received cisplatin compared to cetuximab. And the second study is can we use a panitumab? The panitumab, the recurrent and metastatic spectrum trial was a negative trial, but in locally advanced disease, they're randomized to the concurrent chemoradiation with conventional radiotherapy plus cisplatin standard dose basis, axial radiotherapy plus panitumab. This was given for 9 mg per kg Q once in 3 weeks. And the primary endpoint of this trial was the progression-free survival, and at a median follow-up of 46 months, and there is no difference between the 2-year progression-free survival or 2-year overall survival. I'm sorry to mention that this was a non-inferiority trial design, and the primary endpoint was not met. And in the HPV positive disease, can we replace cisplatin with a monoclonal antibody, cetuximab? There was 2 attempts. One from the American group, that is the RTOG 1016 trial, and the other were from the UK group, the de-escalate trial. Both published in the same edition of Lancet in the January 2019. The NRG trial, that is the RTOG 1016, was presented in Astro annual meeting in 2018, published in January 2019. Both published in 2000. There is a slight difference in the inclusion criteria between the 2 trials. The de-escalate trial used the low risk patients. In the RTOG 1016, it was low risk and intermediate risk patients. The toxicity was the primary endpoint of the de-escalate trial. The overall survival was the endpoint in the RTOG 1016. The same regime was used. The standard, the IMRT plus radiotherapy, IMRT by radiotherapy plus cisplatin, or IMRT plus cetuximab. And when we look into the results, they concluded that we cannot replace cisplatin with a monoclonal antibody. And in terms of overall survival and the local control were better in patients who received cisplatin plus radiotherapy compared to the cetuximab plus radiation. And we are not in a position to de-intensify in HPV positive CA oropharynx. That was conclusion. Now coming to the last part, that is, can we use induction chemo? So you give TPF, induction chemo, followed by a monoclonal antibody plus radiotherapy basis the standard concurrent chemoradiation. There are 2 attempts, one by the Gottlieb group, that is in 2007-02, and other by the Italian attempt. This is the Italian attempt. That's a phase 3 randomized trial of induction chemotherapy. That is, you give TPF 3 cycles followed by radiation plus cetuximab, or no induction. That's a standard concurrent chemoradiation. The primary endpoint was overall survival, and this was published in Oncology in last year in 2020, and it showed that the 2 graphs are hugging each other. There is no difference between the outcomes. And the same design by the Gottlieb group 2007-02. This was published in JCO in 2018, and this was mainly for bulky tumors, because is there any benefit of adding a TPF before the cetuximab plus radiation? That was the primary endpoint. So the progression-free survival was the primary endpoint, and the data showed that there is no difference between any of the parameters. Although there was a borderline statistical significance for distant metastasis-free survival, in terms of progression-free survival, local control, and overall survival, there is no difference. So the TPF followed by cetuximab plus radiation is also not considered as a standard approach compared to concurrent chemoradiation. So if I conclude, the anti-EGFR therapy in locally advanced head and neck squamous cell carcinoma is, if we compare to radiotherapy, that is the Bonnet trial, there is an increase in overall survival, local control, because when we compare radiotherapy alone, there is a benefit with an increase in toxicity. And compared to concurrent chemoradiation basis, concurrent chemoradiation plus a monoclonal antibody, there is no benefit in terms of overall survival. All the 3 trials fail to show overall survival benefit. The TMH trial showed an improvement in locoregional control and progression-free survival. And all the 3 trials showed an increase in toxicity. And is there any benefit by adding chemotherapy in addition to cetuximab plus radiation? There is an added benefit in terms of progression-free survival. And can we replace a monoclonal antibody with a cisplatin? No, it is inferior outcomes are there. So you cannot replace either in the whole population or in HPV positive patients. Can we use induction chemo followed by cetuximab plus radiation versus the concurrent chemo radiation? Again, there is no benefit. So that is the conclusion from the anti-EGFR therapy. So to conclude, it can be clearly if we are using only radiotherapy, or you cannot give a monoclonal platinum by any of the reasons, by due to a poor general condition or due to an advanced age or deterioration of the performance status, you may consider a monoclonal. Now, this is one of my review articles which was published a few years back, the current status of anti-EGFR therapy in the curative treatment of head and neck squamous cell carcinoma. Now, coming to the immunotherapy in locally advanced disease. The immunotherapy has been a standard in recurrent metastatic disease in second line and first line treatment. In the second line treatment, we have the Checkmate 141 clinical trial, the Keynote 040 trial, Keynote 040 trial. The Checkmate trial was initially published in New England Journal of Medicine in 2016. Then there was an update in Oral Oncology in 2018. The Keynote 040 in second line was published in Lancet in 2019. And all this have shown that there is a benefit, even if there is an improvement in overall survival. In the first line treatment, we have the Keynote 048 clinical trial. There is a 3-arm clinical trial. That is the chemotherapy plus the cetuximab versus immunotherapy alone, or chemotherapy plus immunotherapy 3-arm trial. Again, these have shown an improvement compared to the extreme regime. That is the chemotherapy plus cetuximab. So this has been a standard in recurrent and metastatic disease as of now. But what is the role of immunotherapy in locally advanced disease? That is the point I'm going to discuss now. So how the immunotherapy, Dr. Sayan, can I take another 5 more minutes? Okay, I will wind up in, yeah. Okay, thank you. So if you look into how the immunotherapy works, so we have the the PD1, this from the T cell, and also the PDL1. This is a tumor cell. So when you bind the PD1 from the tumor cell and PDL1 from the tumor cell, then what happens? And this occurs, and this will lead on to the binding leads to inhibition due to the T cell killing of the tumor cell based on the T cell. So the action of the T cell is blocked. Once you use either a PD1 inhibitor, that is a T cell, the PD1 inhibitor, or a PDL1 inhibitor, then this blocking of the PDL1 or PD1 allows the T cell killing of the tumor cell. That is the basic mechanism of using the immunotherapy agent. So when they activate a T cell, it causes the proliferation cytokines, that interferons, and there is a cytotoxic. So when this exhausted, the T cell cannot work. But once you give a PDL1 or a PD1 inhibitor, again it started the effect on T cell. It will again lead on to immune response, and it will lead on to cytotoxicity. And this I have already discussed. So we have the PD1 inhibitor and the PDL1 inhibitor. The PD1 inhibitor is the nivolumab and pembrolizumab. The nivolumab has been approved in the second line treatment, and pembrolizumab has been approved in the second line, first line treatment in recurrent and metastatic disease. And atezolizumab, durvalumab, and avelumab, we do not have any hardcore data in the second line. There was a study called the Eagle trial comparing there are two drug comparing, but there was no benefit. Coming to the radiotherapy and immunotherapy, because there is shortage of time, otherwise I need some time to discuss the mechanism of action, but it has local therapeutic effects as well as systemic immune response. Okay, so if you look into the data, the phase 3 data and phase 2 data. The phase 2 data, there was a study called the GOTEC 2015-01 clinical trial, which was presented in last ESMO meeting. That is called the PEMBRO-RAD trial. It is comparing cetuximab plus radiation versus immunotherapy plus radiotherapy. That was the pembrolizumab. But this was a phase 2 trial. They showed that it is acceptable toxicity, but there is no difference in outcomes. Then the question is, can we use a immunotherapy in addition to the concurrent chemoradiation? This was the avelumab trial presented in last ESMO meeting, published in very recently in April in Lancet Oncology this year. This is randomized comparing the concurrent chemoradiation standard plus concurrent chemoradiation plus avelumab. So when we look into the results, there is no difference. There is no difference either in terms of progression-free survival, which was the primary endpoint, and no difference in overall survival. So there is no, as of now, we do not have any data. There are ongoing clinical trials. This is the last slide. So coming to the ongoing clinical trials, the ongoing clinical trials in immunotherapy in locally advanced disease can be divided into three. One, can we add a immunotherapy? Can we add immunotherapy in addition to concurrent chemoradiation? There is a keynote 412, that is pembrolizumab. In addition to concurrent chemoradiation, this has completed recruiting patients. Around 780 patients have been recruited so far. We may have some preliminary results in any year or two. We may have some results in the next year. So we are awaiting the results from keynote 412. The second is, can we use a monoclonal antibody immunotherapy plus radiotherapy versus an anti-EGFR therapy plus radiotherapy in patients who cannot undergo cisplatin. That is, cisplatin ineligible trials are there. The third group is that, can we use this immunotherapy as an adjuvant? After radiotherapy, you give adjuvant along with radiation or as maintenance. These are the three aspects where all the phase 3 trials in locally advanced squamous plastomas is underway. Thank you very much for your patient listening. Okay, Dr. Sain has asked me to put a page of the book. Sorry, I couldn't, but Dr. Sain has already put. So if you have any queries regarding my presentation, so this is my email ID or this is my WhatsApp. So if you are interested to have my PPT also, I'm ready to share with my residents. Thank you very much.
Thank you, sir. It was a nice talk. It's an excellent presentation, and you nicely sum up what is the current role of targeted and immunotherapy. So as we are running late a little bit, so we'll take the questions at the end, or you can answer the questions in the chat box. So now I invite our third speaker. Third speaker is Dr. Moses Singh. Dr. Moses Singh is a consultant clinical oncologist at the Tata Medical Center, Kolkata, and he has contributed in many chapters, mainly the lung cancer chapters and the genitourinary chapters in our book. Now I invite Dr. Moses Singh for his talk on SBRT in lung cancer. Dr. Moses, please.
Thank you, Shailendra. Are my slides visible?
Yes, sir.
Yes.
Okay. Right. So my talk is to cover SBRT in lung cancer. So I will stick to covering the evidence for SBRT in early stage lung cancers alone. I will not go into the technical aspects of SBRT. So moving on into the talk. So surgery remains the standard of care for any operable lung cancer. And in those with early stage lung cancers like stage 1 NSCLC, in those who undergo surgery, the survival in these patients approach 80 to 90%. But unfortunately, not all of the patients who are diagnosed with lung cancer will be fit for undergoing such rigorous surgeries. They may be unwell for a variety of reasons due to unfit pulmonary functions or cardiac functions as well. And historically, most of these patients were kept on observation thinking that this is just stage 1 cancer. Why do we need to treat them? Their life may be cut short by competing causes rather than cancer itself. But this publication from one case series showed that more than 50% of these patients, these sort of patients who are kept under observation, eventually do die of lung cancer rather than of other causes. So that kind of drove the point home that these patients as well do need some form of oncological treatment. And traditionally, these patients were treated with conventionally fractionated radiotherapy to a dose of 60 to 70 gray over a period of 6 to 7 weeks. But these outcomes with these form of treatments were definitely inferior to that of surgery, and there was a scope for improvement. And a variety of evidences from all dose escalation studies and all those pointed to a fact that possibly there was a role for dose escalation. So people were exploring various options, and it was around this time that stereotactic radiation was being explored in the extracranial setting. And the first reports of SBRT in the extracranial settings were, including the lung cancers, were published by the Swedish group and the Japanese group towards the end of the last century. And since then, there has been an explosion of research and into SBRT for lung cancers. If you do a quick PubMed search, I did this search quite some time back, and with the combination of terms SBRT and early stage non-small cell cancers, this is the amount of results that come up on PubMed. So that shows you the amount of work that went into establishing SBRT as a treatment modality for early stage lung cancers. This review, a systematic review, was published some time back, 2017, published by my friend Patrick Murray from Leeds Cancer Center. So this systematic review looked at more than 4,500 patients, and these were the results from all those patients put together, with excellent 2-year and 3-year overall survival for patients who have such inoperable lung cancers, and excellent local controls and acceptable toxicities. But this was retrospective evidence that we are talking about, or we are talking about prospective single arm centers and all those. But where is the randomized evidence to support SBRT as a treatment for stage 1 lung cancers? So there have been several attempts to compare it to surgery in the patients with operable lung cancers as well. But as you can guess, because of traditional resistance from surgeons to randomize patients to SABR for these sort of patients, most of these attempts have failed. And this is one attempt that most of us would know about. So there were 2 trials called the STARS and ROSEL, which were recruiting, but both of them failed to recruit. So ultimately, they ended up publishing a very pooled data of about just 58 patients who were randomly assigned to either SABR or surgery. And it pointed out that the overall survival is likely to be similar, but it is very difficult to conclude anything from just 58 patients being randomized to 2 arms. The 3-year recurrence-free survivals are also very similar between the 2 arms. But there are renewed attempts at finding out whether SABR can stand a test of strength against surgery in those who are fit to undergo surgery. So several trials like the SABR-2, Stablemates, Valor, and I think there's one more Chinese trial as well that is recruiting. And hopefully these trials can complete accrual, and we will have answer as to whether SABR can be considered a standard of care alongside surgery in operable lung cancers as well. But how does it stand against conventionally fractionated radiotherapy? Is it really better than that? So for that we have 2 proper trials. One is the phase 2 SPACE trial. This randomized 102 patients to SABR versus 3D CRT. You can see PFS rates were similar, and also overall survival did not show benefit in this trial. But there was a larger or a similar numbered phase 3 trial, which looked at freedom from local treatment failure, where a SABR was compared to conventional RT again in those with stage 1 lung cancers. And here SABR was found to be better in terms of local treatment failure and median overall survival as well. The reason why these 2 trials gave different results, we can argue many factors, but one of it could be because of the way SBRT was prescribed in both the trials. You can go through the trial to find out what exactly it was. I think in the phase 2 space trial, it was actually prescribed to the ISO center. So in effect, the periphery was getting a much lesser dose than what we would consider to be standard at this point of time. But in the phase 3 Chisel trial, they made sure that at least 95% of the PTV was covered by the prescribed dose. All these could be the reasons why the two trials gave different results. But nevertheless, we do have at least one randomized trial saying that the standard of care for inoperable small cell lung cancer should be SBRT. If you want to offer SBRT for someone with early stage lung cancer, so these are the eligibility criteria. Most guidelines would keep the cutoff at 5 centimeters or less, and it has to be a node negative lung cancer, and they should not be eligible or not be willing for undergoing surgery. In SBRT, for lung cancers, we always talk about, we dichotomize them into either peripherally located tumors or centrally located tumors. And within the centrally located, there is the ultracentral as well. Why does it matter? In a peripherally located tumor, the tumor is as such is surrounded by pulmonary tissue, and that is essentially the only OAR that we are worried about, and it is a well-known parallel organ. So the toxicity is not really a matter there. But when we look at centrally located tumors, we have several serial OARs, which, if damaged, can lead to serious complications, and that is the reason centrally located SBRTs the reason for classification as such in lung SBRT. So we will look at some evidence for peripherally located SBRT. So most of the trials that we had that I had mentioned earlier were on peripherally located early stage lung cancers, and based on all of them, we have a wide range of dose fractionation available to us for SBRT. And recently, we also have the long-term results from single fraction SBRT as well. So we have this wide range, and most centers, I believe, would choose a risk-adapted approach of in someone who has peripherally located away from the chest wall, being treated with a single fraction or a 3 fraction. But in someone who has contact with chest wall, being treated with a more protracted fractionation of 5 or 8 fractions. This meta-analysis from the Japanese group pointed out that the total BED of any SBRT course should be 100 gray or more for better local control and survival rates, and most of the dose fractionations that we use would reflect this. Moving on to the more controversial centrally located tumors and the role of SBRT in this setting. I had put this up in a previous talk that I had given, that SBRT has kind of traveled the same path that we have all traveled in this pandemic, where we had no restrictions in the pre-pandemic area, and then we, with the WHO warning coming in, we all stopped traveling, and now with better understanding of the disease and controls, we are cautiously reopening up our society, and with the availability of vaccines as well. So SBRT for central lung lesions also has been through similar journey, where it was experimented without any restrictions in the beginning, and then several warnings came and people stopped doing it, and now with several trials running, we are slowly and cautiously approaching it in our clinical practice. So what were the warnings that came up? So this was one of the first report that was published, warning clinicians of excessive toxicities with SBRT for centrally located tumors. And Some of the toxicities that they reported were grade 3 to 4 toxicities of a decline in pulmonary functions, pneumonias, pleural effusions, and skin reactions, and several grade 5 toxicities due to bacterial pneumonia, pericardial effusion, and a patient who had massive hemoptysis. But this patient also had a central recurrence as well. This report analyzed the 2-year freedom from severe toxicity and found that people who had peripheral lesions were much more likely to be free from toxicities than central toxicities and central tumors. And both the univariate and the multivariate analysis showed that hilar at pericentral location were a strong predictor for toxicities. And when this report came out, people with central tumors were found to be at 11-fold increased risk of experiencing severe toxicities compared to peripheral locations. Then there were several other reports as well. So this was another report which pointed out 9 patients with centrally located tumors reporting with bronchial strictures at as early as less than 2 years of follow-up. And another patient, this was another famous report where one patient treated with SBRT in a very ultra-central location had a fatal central airway necrosis at just 8 months post SBRT. But there were several criticisms of these reports. If you, the first one that I mentioned, the Timmerman warning, the main purpose of the study was not actually to look at toxicity of central versus peripheral tumors. This was just something of an exploratory analysis. So this could have been just incidental. In fact, their updated report where they reclassified the locations of the tumors, the increased risk of excessive toxicities in central tumors dropped from just the earlier pointed out 11-fold risk compared to peripheral tumors to just 3-fold risk. And also the SBRT related morbidity and mortality that they had used to define toxicities were very loose definitions. They were not exactly predefined. Infective pneumonias, bleeding from recurrent disease, and respiratory failure were all put down to SBRT related toxicities when in fact they may not have been related to SBRT at all. All these, all said and done, all these reports were written mainly to warn clinicians of the possible excessive toxicities with patients with central lesion locations and the need for trials with different fractionations. And all these led to the definition of SBRT no-fly zone. And I think everyone would be familiar with this picture. So this is a 2-centimeter zone around the proximal bronchial tree. But over a period of time, there has been a refining of the definitions of central lesions with different groups adopting different definitions, including different structures in the mediastinum. In the central lung locations, several retrospective evidences were published after these warnings, showing the toxicity to be acceptable. But retrospective data are retrospective data, so there's no certainty that they would have been treated as they were described, and there are no stringent follow-up protocols, so that could be gross underestimation, and they usually have a very short follow-up. So, and also they usually come from a single center. So we needed prospective evidence for SBRT in some central lung lesions. So there were 2 trials that were done. One is the Nordic HILIS trial. This was a phase 2 trial. 7-grain age prescribed to 65 to 70%, and stratification of tumors close to main bronchus and to lobar bronchus. They had a very high grade 3 to 5 side effects of 28%, and also 7 patients having grade 5 side effects of lethal hemoptysis in 6 patients. And this was the other dose escalation study that was done, RTOG 0813. This was to identify the maximum tolerated dose. So at dose fractionations ranging from 10 to 12 gray per fraction over a 5-fraction schedule. And the dose-limiting toxicity would be any grade 3 or worse predefined toxicity within the first year. And the MTD would be the dose at which 20% or more toxicities were happening. At a follow-up of 33 months, the 12 gray per fraction had more than 20% toxicities, whereas the 11.5 gray had 16% toxicities with grade 5 pulmonary bleeding happening in 4% patients in the highest dose groups of 11.5 gray and 12 gray per fraction. With all these, meta-analysis also was done about this included 600 patients from 13 studies. The pooled 3-year local control rates were 72%, and an acceptable grade 3 or more complications of around 12% was reported in this meta-analysis. So it is always a trade-off in radiotherapy, as we all know, between complications and local control. We had earlier seen that BED of more than 100 gray is needed for better local control, and this was again reiterated in this meta-analysis as well. But we also see that the grade 3 or more complication rates are higher if we keep a BED of more than 100 as compared to less than 100. But we do have a trade-off of lesser local control as well with the lesser BED. So where do we stand in terms of dose fractionation for central lung tumors? These are the different dose fractionations that are widely used. 60 gray in 88 fractions is something that is commonly practiced, and the others could be 50 gray in 5 fractions, or 50 gray in 4 fractions, or the more protracted 70 gray in 10 fractions. So to summarize, most of the guidelines highlight the limited evidence or for efficacy, or that the benefits outweigh the risk compared to more conventional fractionation. For ultracentral tumors, SBRT, that is for the previous statement was for central tumors. And for ultracentral tumors, they definitely do not recommend SBRT outside of clinical trials. Similar sentiments echoed by the Astro Lung SBRT guidelines as well. Again, for ultracentral, they ask us to use a more fractionated than SBRT treatments. Several more trials are in the offing, EOTC, LungTAC, and the Canadian Sunset trials. When these come out, we may have more evidence on safety of SBRT in central lung cancers. So that concludes my evidence review on SBRT in lung cancers. So I would thank Shailendra for inviting me to be part of the contributors for this handbook. It's a very concise review of most of the relevant topics and very useful for students as well as consultants as well. So it is available in the market, and please do support it. And with that, I conclude my talk.
Thank you, Dr. Moses. It was an excellent talk. You have summarized everything, and you have also discussed some very, very important issues. So if we have some questions in the chat box or in the question and answer session, we can take them.
Sir, actually, we do have few questions, but I believe all our speakers are simultaneously also replying to all the questions. Yeah, exactly. Okay. But still, I see some questions. For example, like there could be technical, like cisplatin unfit locally advanced HNN. There's quite a technical question they are being asked.
Yes, cisplatin unfit locally advanced head and neck cancer population often fall in the KPS 60 to 80 group, but Bonner failed to show advantage in this cohort. Should cetuximab be still offered in this group? I think Dr. Cecil, this question is for you.
Yeah, I agree that if you look into the Bonner trial, the average age of inclusion criteria was 55. So I fully agree that in a patient who have, say, 65 or 70 years, there is no clear data to give cetuximab. I fully agree with that, because the elderly patients were not permitted in the Bonner trial. Okay, there is no particular trial evaluating the role of the anti-EGFR therapy in patients who are not eligible for chemoradiation. I also agree to that. In this particular situations, we have to individualize whether to go for radiotherapy alone or to consider cetuximab. Okay, that is your choice. You have to take a choice for that. You have to take a call on that.
Yeah. Thank you. So if we have no other questions, we can conclude the session here. It's already 26 past 9. So thank you all for participating, for your support. So we had almost 125 participants today. I thank each and everyone, and I thank all the panelists. And also I thank our sponsor and the publisher of our book, which is the Handbook of Clinical Oncology, Walter Kluwer. So thank Mr. Sarvanan, and thank Mr. Rabi, and thank Mr. Gagandeep. I thank everyone, and now I conclude the session. And I request you all to see and to check the book that we have edited, which is the Handbook of Clinical Oncology, and give your, after reading, please give your feedback to us so that we can improve it whenever we edit it again in future. Thank you all. Thank you, and good night. Now I am closing the session.